Hello, everybody. Thank you very much for asking me to speak about home dialysis and what the evidence is to pursue a policy of advocating for home-based dialysis for our patients. Here are my disclosures. And I'm going to focus on two broad topics. The first is survival among the different dialysis modalities, and the other is on quality of life. So let me first talk about survival. I think the study that had us all focusing on survival was this one by Wendy Bloomberg and colleagues that came out in 1995. And what Bloomberger and her colleagues did was to look at deaths on patients on in-center hemodialysis and peritoneal dialysis. And what she found was that there was an overall increase in mortality in patients on PD compared to those on in-center hemo. And this was an even higher relative risk of death in patients who were older and also had diabetes. Now, this particular study was based on Medicare data. And for those of you who don't deal with Medicare data, it's interesting that there is a 90-day censorship from the start of in-center hemodialysis before the Medicare data is registered and reported. Therefore, anybody who started on in-center hemodialysis covered by Medicare and died within the first 90 days would not be captured, and indeed were not captured in this particular study. As it turns out, and something I'll come back to later, early deaths are more common in in-center hemodialysis than they are in peritoneal dialysis. So those of us in the PD world thought that this was basically unfair because a lot of the hemodialysis associated deaths were occurring in the first 90 days and were missed by this and many other similar analyses. Now, this was in 1995, and around that time, many people feel that the popularity of PD started to drift off. And many people blame the Bloomberg study. It got a lot of press. I had patients calling me, other people had their PD patients calling them. And we still don't know if, in fact, it was the publication of this particular study in a high impact journal that led to this, or there are alternate explanations. First of all, some workers feel that the prevalence of peritoneal dialysis was indeed falling even before the publication of this study. And certainly in my part of the world, it was coincident with the opening of a lot more satellite hemodialysis units, and maybe just patients who before did want to do in-center hemodialysis and would rather be closer to the rate where they lived, with the opening of now more neighborhood hemodialysis units, maybe that was the reason why fewer people were interested in doing peritoneal dialysis. But certainly this idea of increased mortality on PD compared to in-center hemo gained a lot of traction. Now, it was an observational study, and it's really hard, as you know, to avoid flaws in observational studies. How do you control for healthier versus sicker patients, for the particular type of patient who wants to do their dialysis at home, and for recruitment bias? So ideally, the best way to compare mortality of peritoneal dialysis and in-center hemodialysis would be a randomized controlled study. And that is exactly what the Dutch decided to do. So they wanted to have a group of patients who were capable of doing either in-center hemo or home peritoneal dialysis and randomize them into one or the other modality. The interesting part of this was that it was impossible to do. Of the 773 patients who could do either, only 38 agreed to be randomized. So you can see one bar is the number of eligible patients, and the other is just the 38 patients who agreed to be randomized into the study. And that was really the point of their Kidney International paper, that some people wanted to do hemo and some people wanted to do PD, and the vast majority refused to be randomized. In those 38 patients who agreed to be randomized, of course, you have to take this with a measure of a grain of salt because it's such a small number. The hazard ratio was higher for death, or in other words, there was less survival in the hemodialysis patients than the peritoneal dialysis patients. No difference in quality of life, but again, this was based on a very small number of patients, and they correctly assume that the main take-home message from this is that people want to choose their modality of dialysis and that a randomized controlled trial would be very difficult to do. And that's the way it stayed for over a decade until a second randomized controlled trial was attempted in China. Now, this has been presented at congresses but hasn't yet been published. It was an ambitious study with many sites across China, and it was also supposed to be a survival study. The problem was that if you look at the recruitment population, it was a young, non-diabetic population. And therefore, fortunately for the patients, but unfortunately for the trial, there weren't enough deaths to look at survival between the two modalities. Therefore, they decided to rejig the whole study and make it instead a quality of life study comparing hemodialysis to peritoneal dialysis. And that's, of course, problematic. They looked at non-inferiority, and what they found was that quality of life was non-inferior on peritoneal dialysis compared to hemodialysis. And interestingly, it was also further clouded by the point that many patients dropped out of their assigned modality, especially if they were assigned to in-center hemodialysis. So we have a couple of ambitious, but ultimately perhaps failed survival studies. And I would hazard to say that it looks like a randomized controlled trial of PD versus in-center hemo is not going to happen. And therefore, we are stuck with looking at observational studies. And as I said before, you have to control for the different factors in the different modality groups. Now, the choice study to me was an important lesson in trying to control for factors. And as many of you know, the choice study looked at about 1,000 patients in this cohort. It was in the late 90s. They were self-reported baseline characteristics, including residual urine output. They look at deaths in this in both unadjusted, multivariate, and propensity adjusted models. Now, what were the results? After a mean 2.5 years, the death rate in the PD population was 21.2%, and in hemodialysis was 24.4%. Now, looking at it another way, again, here's the same numbers. Looks to me like there's more mortality in in-center hemodialysis than there is in peritoneal dialysis. However, when you do the adjusted survival, and I show you this on this table, you can see that the hazard ratio for death in the second year for PD versus hemo, so any number greater than 1 means a greater risk of death for PD compared to hemo. Any number less than 1 goes the other way, that there's a greater risk of death for hemo than for PD. So the unadjusted was basically a wash, 1.06 with very wide confidence ranges. And then the authors adjusted 3 ways, even when they adjusted for demographic characteristics. So that would take into effect, and take into account age, comorbidities, things like that, education, things like that. And you can see that the adjusted hazard ratio for PD compared to hemo is 0.77. Again, widely stretching over the number 1, but still it's not jumping out that there's a greater risk with PD. When they then added in clinical and treatment factors, the hazard ratio is still 0.84, again, with a wide splay. Then they added in laboratory values. And when they adjusted for laboratory values, suddenly everything changed. And now the hazard ratio for death, remember, it was 24% in hemo and 21% in PD. When they added in laboratory values, suddenly the ratio, the hazard of death in PD was twice as high as it was in hemo, and it escaped the nefarious 1.0, so it was statistically significant. So adding in the laboratory values changed everything. And this really was a very important lesson to me. And at the same time, I was reading Freakonomics, and they said that regression analysis is more art than science. Now, if I were one of the authors of that paper, I would have said, well, that's weird. 0.77, 0.84, then you add in laboratory values, and all of a sudden everything changes. And as I said when I wrote this editorial about this, worshiping at the altar of St. Cox, who adjusts the adjustments, a biostatistician can hand you the data, but they have to make sense to you. And I would have said, well, what was it about the laboratory values that changed everything so dramatically? Did they adjust for residual urine output, which happens to be usually much greater in PD patients than in in-center hemo patients? Was that the issue? We don't know any of that. All we know is that with the adjustment, suddenly the death rate in PD became twice as high as it was in hemodialysis. And this is, again, I had all my patients telephoning me about this, saying that I was trying to kill them. And this is something from Nephrology News and Issues. And, just read the title. Peritoneal dialysis has a higher death risk than hemodialysis, with no one looking at the so-called statistical fine print. Now, there was a whole industry that looked at survival analyses, and this was really during the 1990s and the early aughts, and there were a number of studies that looked at survival differences between these two modalities. Ed Vonish was involved in a lot of these, and those of us who were reading the literature at the time saw a lot of these graphs. So let me just say briefly that this looks at relative risk of death of hemo compared to PD. You can see that in all of these, whether it's by age going from left to right, and comorbidity, in this case diabetes, in the bottom panel compared to the top panel. Anything above 1 is a greater risk for hemodialysis, and anything below 1 is a greater risk of death for peritoneal dialysis. And this is all over time. And you can see that really only in the patients who were non-diabetic, especially if they were young, that there was a survival advantage for PD, or in other words, a greater risk of death for hemo compared to PD, which trailed off after a couple of years, and then it basically became a tie, going along the number 1. Whereas if you look on the bottom panel, patients with diabetes, and as you go across from left to right, you can see that in the younger age group, again, there was a greater relative risk of death in the hemo patients early on, and then it sort of leveled out. But when you get to the older diabetic patient, you can see that it's sort of more dominated by a greater risk of death in peritoneal dialysis patients, especially again in the middle-aged and older diabetic patients. And everybody was examining these kinds of graphs. This is the same sort of thing from Vonesh, but now looking at patients who reported at least one comorbidity. And when you factored in the comorbidities, again, there was a pattern of an early higher risk of hemo compared to PD, but as you went on, there was a greater risk of death in peritoneal dialysis. And that was the message that everyone basically got. This was from Steve McDonald looking at the ANZAC data. Again, younger patients with no comorbidity in the top left, it was basically a wash. Whereas in the other groups, older patients, and especially older patients with comorbidities in the bottom right, that there was a signal that after a couple of years, the survival curves start to splay with a survival advantage for hemodialysis over peritoneal dialysis. Similarly, with the Dutch NECASAD experience, an early increased risk of death with hemodialysis, and then after a couple of years, in this case after 3 years, an increased risk of death with peritoneal dialysis. So there were many, many of these studies, and one of these, we put them all together. And of the 22 registry studies that did report mortality as an outcome, in half of them, there was no difference between PD and hemo. 4 showed a survival benefit for PD, and 6 a survival benefit for hemodialysis. All this time, when all these papers were coming out, I was shaking my head and saying, is this important? My patients, when I talk to them about PD versus hemo, they ask a lot of questions, but I had never got the question, which one will I live longer on? Now, the patients sometimes said, which one is better? And you could interpret that as saying better means which one will I live longer. But I didn't think that was the sense. It wasn't a question that was being posed to me, which one will I live longer on? So let's even say with all the problems of those studies, just for the sake of argument, let's say there was a higher long-term mortality risk with PD compared to hemo. Does that mean that patients should not go on to PD? Is everything with dialysis and choice of modality related to something that will maximize survival? So this was further, I think, cemented by this great study that was done by Braden Mans and colleagues, and they asked patients and their caregivers, what should we be doing research in? Or in other words, what is important for you? And the most important issues for the patients was how to get out of the hemodialysis chair as fast as possible. What are we going to do about itch? Fatigue and low energy comes up over and over again as one of the most important factors that the dialysis patients themselves want to see research into. And how can I do dialysis and go traveling also? For the caregivers, it was how to slow progression or prevent CKD, improve quality of life. How do we lower wait times for kidney transplant? And what do we do when dialysis just isn't appropriate anymore? You can see that in the top questions and the research priorities for the patients themselves, especially, and also for the caregivers, that choosing a modality that makes the patient live the longest is not really one of their priorities. It's really living better rather than living longer. However, when you ask physicians, then modality of dialysis and survival does come up. This is something that was more important to physicians than it was to the patients themselves. And it's really interesting because in those bad old days, after the Bloombergen and Vonesh and McDonald studies, there really was a signal that older diabetic women had a better chance of survival on hemodialysis than peritoneal dialysis. So even if an older diabetic woman wanted to do home peritoneal dialysis, many nephrologists said, no, you can't do that, and assigned them to hemodialysis, which is interesting, of course, because in these same registry studies, you could say that a 25-year-old man with IgA nephropathy, by the same registry studies, would have a better chance of survival on peritoneal dialysis than on hemodialysis. But my sense was that the same nephrologist did not say, no, you can't do hemodialysis, you have to do peritoneal dialysis. So it seemed like what worked, what was good for the goose was not good for the gander. So after the studies, which seemed to point out that there was this early survival advantage with PD compared to hemo, and that this advantage dissipated after anywhere, depending on the study, 1 to 3 years, that maybe we should have integrated care to what I call kind of surf this wave. Start with PD while the going's good, if you will, and then after a couple of years, transitioned to hemo to ride that wave of hemo survival becoming better than PD. And this is another head scratcher for me. This surfing of the survival data never made a lot of sense to me. And to me, it's like, if I have a baby, I want to maximize this baby's chances of living. So you look up and you see that the lowest infant mortality rate in the world is Iceland. So you go to Iceland and you have your baby there. And then when the baby is younger, you move to Australia, because in Australia, they have the lowest under 5 mortality rate in the world. And then guess what? After 5, Andorra has the lowest mortality rate for children aged 5 to 14. So I'm going to surf and have my baby in Iceland, move to Australia, and then move to Andorra. That makes no sense at all. And yet that seems to be the kind of thing that people were advocating in starting with PD and then moving to hemodialysis. I think all of this over the time slowly became perhaps a little more moot. Raj Malhotra, Eric Weinhandel, and others showed in later studies, now going into the second decade of this century, showed basically no difference in survival between peritoneal dialysis and in-center hemodialysis. And, I forget with Malhotra's study which one's which, but you can see basically that the two survival curves are essentially superimposable. And then I think for me, the aha moment was this, which I think is one of the best papers that has ever looked at survival differences between PD and hemo. And this is from Rob Quinn. And he basically said, let's look at a level playing field. Let's start with patients who had pre-dialysis care and an elective outpatient start, a level playing field. And what he found was, in fact, there was no early survival advantage for PD. But importantly, I think there was no late survival disadvantage for PD. Basically, again, the lines were all superimposable. Further adding to that was Jeff Pearl's study, where he looked again with adjusting the survival of hemodialysis patients across Canada, depending on what kind of vascular access they had. And you could say that the vascular access itself it's intrinsically harmful, or it could be a surrogate for poor pre-dialysis care, a non-adherent patient, and so on. And in fact, when you did that, you saw that the early survival advantage for PD, or in other words, the increased hazard risk for hemodialysis, was only seen in the subgroup of hemodialysis patients who started the dialysis with a perm cath. So these studies changed my own thinking. I really don't think that there's an early survival advantage to PD. I think that there is an early survival disadvantage to hemodialysis. And that is probably a marker for unprepared starts, urgent starts, the non-adherent patient who waits till they're almost dead to start on dialysis. The perm cath itself may be a source of risk. And of course, hemodialysis may be a cardiovascular stress test and kill off some patients who have very borderline cardiovascular reserve. So the final straw for me came when I was asked to review yet another study that looked at survival by dialysis modality. And I said, really, do we need any more of these? And Martin Lee and I wrote this editorial that really caused quite a buzz. And really, who does care? Certainly not the patient, not the caregiver. Why are we still looking at this? And this leads into the idea of quality of life. And this is the patient focused quality hierarchy, where the most important thing is health related quality of life. Then other things, yes, mortality is important, but it's not the be all and end all. as I said, living better, not living longer, hospitalizations, things like that. And you can see the way that this goes. I'm sure you're all familiar with this particular figure. So this leads into quality of life and home versus in-center dialysis modalities. Many of you may not be familiar with this. This is at a time in 1985 when, again, there was more home hemodialysis before it started falling off, and more PD before it started falling off, as I mentioned before. And it looked at quality of life by modality. And basically, the take home message from this New England Journal paper was that the best quality of life was in patients with a kidney transplant. But after that, home hemodialysis and peritoneal dialysis had a better quality of life compared to patients who were on in center hemodialysis. And certainly that would jibe with, we did a survey in our own PD unit. We never published this, but I just think it's so interesting. We asked our PD patients, how would you rate your health? Now, these are patients who, on average, have the same average survival as someone with a diagnosis of colon cancer. And yet you can see that the majority of the patients rated their health as good, very good, or excellent. And again, I think this speaks to the quality of life and the perception of their patient on the modality that they happen to be on. And this is a Delphi panel that was recently published that looked at, again, very similar to what I said before, what's the difference between health professionals versus the patients and their caregivers. And again, I just want to point out where the asterisk is that death is more important to the health professionals than it is to the patients and their caregivers. And in this visual abstract from the same song paper that was published, you can see in the last box that the most important patient reported outcomes to the patient was their ability to do their activities of daily living. Again, fatigue is really important, and depression. So we did a study in our own center where we have a very large peritoneal dialysis and a large nocturnal home hemodialysis program. And to my surprise, we saw that there was really no difference in quality of life between nocturnal home hemodialysis and peritoneal dialysis, especially for a couple of interesting things was that the PD patients felt just as well as the home hemodialysis patients. The home hemodialysis patients, interestingly, had a better sex life than the PD patients, but they were also about 20 years younger. And the amount of work involved in the patients was just as much, perceived to be just as much for the PD patients as it was for the nocturnal home hemodialysis patients. It was very revealing. And then I think this quality of life study from Bruce Culleton was perhaps misinterpreted. They looked at patients and decided to do a randomized trial of nocturnal home hemo versus patients staying on in center hemodialysis. Now, the patients who were part of this trial all wanted to go onto nocturnal home hemo. That was the baseline cohort, but they couldn't accommodate them all. So they decided to do it as a randomized trial. And what's interesting is if you look at the blue bar, and look at pre-randomization and then to baseline, the biggest jump in the quality of life in the blue, which is the patients who were randomized to nocturnal home hemodialysis, was even before they started on nocturnal home hemodialysis. In other words, they were just, I think they had a big jump in their quality of life because they wanted to dialyze at home. And they were the lucky ones who were chosen to be randomized to the nocturnal home hemodialysis. Whereas, as you can see, there was a bit of a drop in the in center hemo patients who were wanting to go on home hemo and were not randomized to the home hemo. And that was really, I think, what caused the difference. And Braden Mans, in a subsequent analysis, really ended up concluding that there was no difference in quality of life, in the no significant difference in the nocturnal home hemodialysis patients. Now, of course, we now have the inevitable systematic reviews and meta-analyses looking at quality of life in these patients. And I just point out one of them. There's at least one other one, but you can see of all the studies that looked at this through the culling procedure, because there was so much heterogeneity among the studies, that in the end, they only ended up with 17 studies with the SF36 and 5 each of the EQ5D and the kidney disease quality of life studies. And if you look at this systematic review and meta-analysis, and again to the right are things that favor peritoneal dialysis with the SF36. The results are very similar for the other ones too, but this one had the most studies. But you can see that a lot of these crossover one, but the lay of the land is mostly favoring peritoneal dialysis as a home modality compared to in-center hemodialysis. So again, this probably depends on, where this is being done. What is the PD program like? What's the in-center hemo program like? When you're doing worldwide studies, there are just so many variables in the quality of the programs. So that's really a 25-minute romp through the evidence. Let me just nail it down to about 4 points. And that is that if you're looking at survival, the contemporary survival studies don't show a difference between in-center hemodialysis and peritoneal dialysis. The so-called early survival benefit of PD that many people, including dialysis corporations, are still touting is probably relating more, I think, to an early survival disadvantage with hemodialysis, especially in hemodialysis that is confounded by acute starts and by the type of vascular access that the hemodialysis patient has. Patients themselves are more concerned about their symptoms and their functioning and their quality of life than they are about which modality will let me live the longest. And there is at least a signal for a better quality of life in home based dialysis compared to in center hemodialysis. But again, this probably depends on what the quality of the programs are like themselves. Thank you very much, and I'm happy to take questions.